Welcome to the Australian Dental Council Explainer podcast.
It's great to be here.
Okay, picture this. You have a 30-year-old female patient in your chair.
Right?
It is a completely routine scaling. But right now, she is burning up.
Oh, wow.
She's suddenly gasping for air, and a diffuse blister-like rash is rapidly spreading across her face.
That's a nightmare scenario.
It really is. So pause and think about this right now. What is your initial differential diagnosis?
Because, the clock is absolutely ticking here. The patient is in severe distress, and your cognitive architecture needs to immediately shift.
Exactly. And while you, the listener, hold that terrifying scenario in your mind, let me just quickly state that this deep dive is purely educational.
Right. Very important.
Yeah, it is designed specifically to support clinical learning and is absolutely not a commercial endorsement of any products, brands, or textbooks that we might mention today.
We are just here to analyze the clinical reasoning, the underlying pathophysiology and the science, nothing else.
Yep, nothing else. So with that out of the way, a massive welcome to you, the listener.
Welcome, everyone.
Whether you are an overseas-trained dentist, an OTD working towards your qualifications, or an ADC candidate deep in OSCE prep, an Australian oral health therapist, or just a dental student anywhere across the world, this custom-tailored deep dive is built for you.
It really is.
Today, we are dissecting a cornerstone of modern dental pedagogy. We're pulling directly from the highly acclaimed textbook, Odell's Clinical Problem Solving in Dentistry.
A fantastic resource.
It is. Specifically, we're looking at Case 3, which is ominously titled An Unpleasant Surprise.
Yeah, it's a very fitting title, honestly, and it perfectly encapsulates why the Odell series, which is led by Professors Banerjee and Thavaraj, is so universally respected.
Wait.
We have moved away from that old school, heavy reliance on didactic, lecture-based instruction.
Oh, yeah, the era of rote memorization, just, staring at lists of symptoms and hoping they stick in your brain.
Exactly, and that approach just doesn't survive contact with reality.
No, it doesn't.
The shift in modern teaching has been toward this integrated, case-based clinical reasoning model. The text forces the reader to reorganize isolated academic knowledge into a practically applicable format.
Because that's how it happens in the clinic.
Right. It mimics the sheer unpredictability of a real dental practice. Because in the real world, patients don't present as neat textbook chapters.
I really don't.
They present with complex, overlapping physiological variables.
Okay, let's unpack this. We left you with a patient fighting for breath.
Yeah.
And to demonstrate the evidence-based reasoning that Odell's book champions, we can't just react blindly to the rash. We must systematically unpack the patient's medical history to understand why her body is doing this.
Absolutely. The diagnostic process in dentistry requires a sophisticated interplay between intuitive pattern recognition and, deep analytical reasoning.
Yeah.
You have to look at the history to decode the acute presentation.
And looking at the medical history provided in the text, there are some massive red flags.
Huge ones.
She is a well-controlled asthmatic, using salbutamol on occasion. She also suffers from eczema, requiring a topical steroid cream.
Right.
And the genetics are clear, too. Her mother and her 2 children also suffer from eczema. Think of her immune system like a dry forest, just waiting for a spark.
Right. That is a perfect analogy. Those aren't just background details. They form the very foundation of our diagnosis here.
Yeah.
The presence of asthma and eczema strongly signals a hyperreactive immune system. Clinically, this is known as the atopic triad when you include allergic rhinitis.
Right, the triad.
This patient has a documented genetic predisposition to mount exaggerated, Ig-mediated immune responses to otherwise harmless environmental triggers.
Or, in the context of our specific case, a pharmacological trigger.
Precisely.
Because 45 minutes before she started gasping for air, you administered a 3-gram oral dose of amoxicillin for antibiotic prophylaxis.
Right.
And here's the curveball in the case file. And I know this trips up a lot of clinicians when they're under pressure.
Oh, absolutely.
The patient explicitly states she has had antibiotic cover before.
Okay.
Presumably amoxicillin or another penicillin without any incident whatsoever. She was totally fine.
Yeah, and that specific detail is a trap.
A trap.
Yes. It tests a clinician's vulnerability to premature closure, which is a highly dangerous cognitive bias.
Oh, wow. Okay, explain that.
Well, premature closure occurs when a clinician settles on a diagnosis or prematurely rules one out before considering all the physiological realities.
Let's say you just stop thinking.
Exactly. The clinician ignores the glaring acute symptoms simply because the patient has been, quote-unquote, fine before. Odell's series is structured to force you to confront and overcome this exact bias.
It's like the first time she took amoxicillin. The drug was a scouting party.
Right.
It didn't attack her, but it allowed her immune system to take photos and print a million wanted posters.
I love that.
Those IgE antibodies, right?
Yes, exactly.
And now, on the second exposure, the immune system recognizes the fugitive instantly and just launches the nukes.
That captures the mechanism perfectly. What you are describing is the fundamental difference between the sensitization phase and the effector phase of a type hypersensitivity reaction.
Lucky.
A severe allergic reaction often requires prior exposure.
Wait, really? It requires it.
Yes. The immune system needs that first harmless encounter to become sensitized. It creates the specific IgE antibodies against the penicillin molecule and attaches them to the surface of mast cells and basophils.
So she was fine the first time because her immune system was just busy building the weapon.
And arming it.
Wow.
Now, upon this subsequent exposure, this massive 3-gram oral dose, the amoxicillin molecules bind to those waiting IgE antibodies.
And that's what sets it off.
Right. This cross-linking triggers an explosive degranulation of those mast cells. They dump massive amounts of histamine, leukotrienes, and prostaglandins directly into her systemic circulation.
The takeaway for anyone sitting in OSCE is huge here. Do not let historical safety blind you to an acute crisis. The fact that she had it before isn't a reason to rule out an allergy. Physiologically, it's actually the prerequisite for it.
Exactly. You must prioritize the acute clinical signs occurring in front of you over historical assumptions.
Okay, so her immune system was secretly armed and waiting. But how does that invisible microscopic sensitization suddenly turn into the physical horror show happening on her face right now?
Well, we have to look at the tissue itself.
Let's look at the actual rash and technically define the physical symptoms.
Yeah, so the primary visual symptom in the source text is described as an urticarial rash.
Okay.
And to diagnose accurately, we have to move beyond lay terms like hives and define the underlying pathophysiology.
Because urticarial actually comes from the Latin word for nettle rash, right?
It does.
Yeah.
And clinically, an urticarial rash is characterized by superficial edema.
Okay.
When those mast cells degranulate and release histamine, it causes profound local vasodilation. The blood vessels just widen, but more importantly, it increases vascular permeability. The endothelial cells lining the capillaries actually pull apart slightly.
Oh, wow. So they create gaps.
Exactly. This allows fluid or plasma to leak out of the local blood vessels and into the superficial layers of the skin, forming separate, flat, raved, blister-like patches.
Wait, I'm genuinely confused by something here.
Sure.
If this is a systemic allergic reaction with histamine pumping through her whole body, why does the text specifically highlight that the rash on her face and neck is diffuse, rather than presenting as those distinct, separate, raised hives you typically see on an arm or a torso?
That's a great question.
Why is the anatomy of the face changing the physical shape of the rash?
That is a brilliant anatomical distinction to pull from the text. It really comes down to the varying structures of connective tissue across the human body.
Okay.
The tissues in the head and neck region, particularly around the eyes, lips, and facial planes, are remarkably lax.
Meaning they're stretchy.
Yeah, they lack the dense binding connective tissue found in the dermis of the limbs or trunk.
So the tissue is physically looser.
Significantly looser. Because of this laxity, when that superficial edema occurs, when plasma leaks into the interstitial spaces, it faces very little mechanical resistance.
Right.
And fluid always follows the path of least resistance. Therefore, the edema is allowed to pool and spread diffusely across the fascial planes rather than being contained in tight, separate raised patches.
That makes total sense. It's a mechanical issue of the tissue itself allowing the fluid to just run rampant.
Exactly.
And Odell points out another fascinating clinical marker to help identify this specific type of rash. If you look at these swollen, markedly edematous areas, they might actually appear pale.
Yes.
But the background tissue around them will be highly erythematous or red.
The physics behind that visual marker are crucial for a clinician to understand. The overall background redness, the erythema, is simply the massive vasodilation.
Because the widened blood vessels are engorged with red blood cells near the surface of the skin.
Exactly.
But what about the pale spots?
Well, the pale spots are where the fluid leakage, the edema, is most severe. As fluid pumps into the interstitial space, it increases the local tissue hydrostatic pressure.
Okay.
If that tissue pressure builds up enough, it actually overcomes the pressure inside the tiny local capillaries, physically compressing them and pushing the blood out of that specific spot.
Wow. It physically squishes the blood vessel shut.
Right. That loss of localized blood flow makes the swollen area appear pale against the red background.
So you get these pale, raised islands in a sea of red, vasodilated skin.
That's the exact clinical picture.
But we aren't just looking at a skin reaction here. This is a multi-system cascade.
Unfortunately, yes.
The text points out that this same edematous process, the vasodilation and fluid leakage, targets the mucous membranes as well.
It involves the nasal and ocular tissues almost immediately. This causes acute allergic rhinitis, a severely congested, runny nose as the nasal mucosa swells in conjunctivitis, which is the red, watery, inflamed presentation of the eyes.
And on top of that, the systemic release of mediators affects the gastrointestinal tract smooth muscle, leading to nausea and vomiting.
Yeah.
So what does this all mean? We have a patient fighting for breath. We have a diffuse urticarial rash on the lax tissues of the head and neck. We have rhinitis, conjunctivitis, and nausea.
It is the textbook presentation of an acute systemic allergic reaction rapidly progressing toward full-blown anaphylaxis.
Here's where it gets really interesting, because making the diagnosis is only half the battle.
Right.
If you are sitting in the ADC OSCE hot seat, or if you are standing over your actual dental chair, knowing it's anaphylaxis doesn't save the patient's life.
Yeah.
Action saves the patient.
Absolutely.
And panic is the absolute enemy here. So what are the exact step-by-step physical actions the clinician must take right now, according to the source material?
Well, in a rapidly escalating medical emergency, you need ingrained algorithms, not guesswork.
Yeah.
And the Odell text is highly prescriptive. The immediate management protocol always starts with the airway and breathing. Step 1, you must allow the patient to adopt the most comfortable position for breathing.
I really want to highlight this because our reflex in a dental setting is often to lay the patient completely flat the moment they feel unwell.
Right, which is dangerous here.
We're trained to do that for a vasovagal syncope, right?
Yeah.
It's a faint, to get blood flow back to the brain.
Yeah, but applying the syncope protocol to a respiratory crisis is a critical error. Let's look at the respiratory mechanics at play.
Yeah.
This patient is experiencing acute shortness of breath, likely due to histamine-induced bronchospasm. The smooth muscles surrounding her airways are contracting violently.
She is fighting to pull air into her lungs.
Exactly. And if you force her to lie completely flat supine, you add a massive mechanical burden to her breathing.
Because of gravity in her own anatomy.
Yes. When supine, the abdominal organs push up against the diaphragm.
Oh, right.
The diaphragm is the primary muscle of inspiration, and now it has to fight against the weight of the viscera just to descend and create negative pressure in the chest cavity.
That makes it so much harder to breathe.
Furthermore, sitting upright allows the patient to effectively use their accessory muscles of respiration, the muscles in the neck and chest wall.
To help pull the rib cage open.
Precisely. You must let them sit up, lean forward, or adopt whatever posture helps them mechanically move air.
Okay, patient positioning is step 1. Do not force them flat if their airway is compromised. What is the immediate next step for their respiratory distress?
Step 2 is the administration of oxygen, and the text provides a very specific physiological parameter that you must understand and commit to memory.
Which is?
You administer oxygen at a flow rate of 5 liters per minute via a simple face mask.
5 liters per minute, not 2, not 15, 5.
Exactly 5.
I imagine in an exam scenario, the examiners are listening for that exact number because it demonstrates precision under pressure. But let's break down the why. Why exactly 5 liters per minute?
It comes down to the mechanics of the equipment and the patient's respiratory drive. A standard, simple face mask, often called a Hudson mask, has a certain amount of internal volume, which we call dead space.
Right.
When the patient exhales, their carbon dioxide-rich breath fills that dead space inside the mask.
So if the fresh oxygen flow coming through the tube is too low, say 2 or 3 liters per minute, it doesn't create enough pressure to physically flush that exhaled carbon dioxide out of the exhalation ports on the side of the mask.
That is the exact danger. If the flow rate is too low, the patient ends up rebreathing their own exhaled carbon dioxide.
Oh, it's bad.
Very bad. For a patient who is already experiencing bronchospasm and hypoxia from anaphylaxis, increasing their CO2 levels will severely worsen their respiratory distress and alter their blood pH.
So 5 liters is the minimum.
Yes, a minimum flow rate of 5 liters per minute provides enough continuous gas flow to constantly flush the dead space of the mask, ensuring they are breathing fresh, oxygen-enriched air.
That makes perfect sense. So 5 L per minute is the floor to prevent rebreathing. Why not just crank it to 15 liters per minute immediately?
Well, while high-flow oxygen via a non-rebreather mask with a reservoir bag is used in profound emergencies, a simple face mask is often what is immediately accessible in a standard dental clinic setup.
Right. Work with what you have.
Exactly. And cranking a simple mask past its intended flow rate without humidification can dry out and irritate the already inflamed mucous membranes. Plus, it doesn't significantly increase the fraction of inspired oxygen beyond what 5 to 8 liters provides.
Okay.
5 liters per minute is the reliable, safe gold standard for immediate supportive care with standard equipment.
Now, managing the airway and providing oxygen at 5 liters per minute keeps the brain oxygenated, but it doesn't stop the underlying cascade, does it?
No, it doesn't.
The amoxicillin is still bound to the IgE, and the mast cells are still dumping histamine. The text highlights the broader context of anaphylaxis management, which relies heavily on pharmacological intervention.
Right, because oxygen buys you time, but pharmacology saves the life. The text emphasizes that managing anaphylaxis requires being fully prepared with emergency drugs.
Like adrenaline.
Foremost among these are adrenaline, or epinephrine, autoinjectors. Adrenaline is the only medication capable of rapidly reversing the systemic collapse caused by anaphylaxis.
And it does that by brute forcing the body's receptors, right?
It acts on multiple sympathetic nervous system receptors simultaneously. Its action on alpha-1 receptors causes profound vasoconstriction.
Right.
This immediately clamps down those leaky, dilated blood vessels we talked about,
Right.
raising the patient's plummeting blood pressure and reducing the severe mucosal edema in the airway.
So it physically shrinks the swelling that's closing your throat.
Yes. And simultaneously, its action on beta-2 receptors in the lungs causes rapid bronchodilation. It relaxes the smooth muscle spasms and opens the airways back up so she can breathe.
Wow.
It also acts on beta-1 receptors in the heart to increase cardiac output. It is the ultimate physiological counterattack.
The text also mentions potentially utilizing chlorphenamine 10 milligrams intravenously.
Right, chlorphenamine is an antihistamine. It specifically blocks the H1 receptors that histamine is trying to bind to.
Okay.
This helps mitigate the skin symptoms, like the profound urticaria, and stops further histamine-mediated fluid leakage. However, and this is vital, an antihistamine takes time to work.
It's not immediate.
No, it does not act fast enough to reverse life-threatening airway compromise or cardiovascular collapse. It is a secondary, adjunctive treatment. Adrenaline is always the first-line, life-saving medication.
This perfectly reinforces the core premise of Odell's shift in pedagogy that we talked about at the beginning. A modern dentist is not just a mechanic of the teeth.
Not at all.
A dentist is a primary healthcare provider who must be fully intellectually and practically prepared for acute medical emergencies. You are operating on a complex, highly reactive human organism, and sometimes immunology goes catastrophically wrong in a matter of seconds.
You have to be able to synthesize the theoretical knowledge of IgE sensitization and pharmacology with the practical physical actions required in a crisis. You have to know the pathophysiology of superficial edema, but you also have to know the physics of why an oxygen cylinder must be dialed to exactly 5 liters per minute to clear a mask's dead space.
Let's do a quick recap to solidify these essential takeaways for everyone listening. First, we explored the vital importance of synthesizing the patient's medical history,
Right.
recognizing that asthma and eczema represent an atopic triad, a hyperreactive immune system primed to overreact. And we learned to fiercely guard against the cognitive bias of premature closure.
So important.
Just because she had amoxicillin safely before does not mean she isn't having a life-threatening reaction to it right now. The first exposure was just printing the wanted posters.
Second, we technically identified the presentation of an urticarial rash. We understand that histamine causes vasodilation and increased vascular permeability, resulting in superficial edema. We also understand that in the head and neck, this rash appears diffuse due to the anatomical laxity of the facial tissues rather than forming distinct hives.
Right.
We recognize the visual markers of pale, hydrostatically compressed areas on a red, vasodilated background.
And finally, we covered the precise, step-by-step emergency management. You allow the patient to find the most comfortable position for breathing, Do not force them flat, which forces the diaphragm to fight against the abdominal organs.
Exactly.
And you immediately administer oxygen at exactly 5 liters per minute via a simple face mask to flush the carbon dioxide out of the dead space, while preparing to utilize adrenaline to reverse the systemic vasodilation and bronchospasm, followed by intravenous chlorphenamine.
This raises a crucial element that extends beyond the pharmacology, and I want to leave you with a final thought to ponder as you continue your clinical studies. We've talked extensively about the algorithms, the oxygen flow rates, and the receptor affinities.
Yeah.
But drawing from the holistic pedagogical shifts in Odell's text, we have to look at the human element of a crisis.
The actual environment in the room when the patient starts gasping.
Right. When a medical crisis like anaphylaxis strikes, the cognitive load on the lead clinician is immense. How would you manage the human element in your clinic?
That's a huge question.
Consider how you handle conflict resolution or crisis resource management and delegation when seconds truly count. Research shows that poor communication and hierarchical hesitation are major contributors to clinical errors.
Oh, absolutely.
If you need a dental assistant to dial emergency services, another to fetch the oxygen cylinder, and someone to prepare the adrenaline, how do you communicate that clearly, assertively, and without inducing panic?
That is a phenomenal point to reflect on. Knowing the pathophysiology is only half the job. Leading a cohesive, coordinated team in a terrifying high-stakes moment is the other half. You can know all the mechanisms in the world, but if the team falls apart under pressure, the patient suffers. For more dental examination prep tips and clinical deep dives, please subscribe our Spotify and YouTube channel and share this episode.